Hi there, thank you for watching this video. This is about handover and about giving advice. Now, handover refers to the packaging and summarising of the plan that you then hand over to the patient in a way that they can accept it and take it away to action. Doing this efficiently can significantly reduce consultation times if you compare to handing over a plan where you're not really certain and the patient's not really sure if that's what they want, and the consultation can go round in circles for ages. How we achieve an efficient handover overlaps significantly with the previous videos. We take a patient-centered history, we confirm the issues that the patient wants to discuss today, what's the purpose of consultation. We make it clear that we're changing from the data gathering to the management stage. We explain the diagnosis and how we came to that decision. Our management plans will be a 3-step chunk and check approach where there's a suggestion, explanation. We check the patient is happy with that, we adapt it if required, and then we move on to the next bit of the plan. And then this leads up to the moment of handover when we summarise and check for a final time the patient is happy. Body language and tone of voice is important to signpost to the patient that this is the end stage. Right, so you're going to go online and book the blood test. I will request the x-ray appointment and the hospital will send you an appointment in the post for that. You're going to give those exercises a go for a few weeks, and when the x-ray result comes back, I'm going to contact you. Is that all okay? Where things go wrong is when this kind of definite plan is given without the patient-centered build-up. So we're going to look now at how we reach this point. Different patients have different levels to which they want to be involved in decisions, but most patients would want some say in the plan if they were given enough information to make an informed choice. Whether an informed choice is achieved depends on the complexity of the situation and the skill of the doctor to achieve this. Some examples of things the patient will need to make an informed decision include what are the options, what would happen if you did nothing, what are the expected benefits for the patient, what are the possible side effects, what are the difficulties in carrying it out, so for example having to get to the hospital, how long does the treatment last. There are others. Unfortunately, most treatments are not cure or not cure. They're more grey than that, and that's why it needs the patient to be on board with the decision. Expected benefit depends on how good the treatment is, but also how much problem it's causing the patient in the first place. This could be a pain, it could be the effect on their sleep or work, it could be risk of future disease. If a problem is having a 1% effect on the patient's life, then the maximum possible benefit of the treatment is a 1% benefit. Many consultations involve patients presenting with symptoms because they just want a firm diagnosis and explanation, understanding, not necessarily tests and treatments. In general practice, one option only plans are very rare. There are usually choices to be made that the patient will carry out over weeks, months, years. So the patient has to understand and be on board with this for this to actually happen. In a previous video, we looked at defining the issues to make sure the doctor and the patient know the purpose of the consultation. What does the patient actually want from us today? The phrasing we looked at the start of the management plan, management section, alerts the patient that this is going to be a shared decision. We will need to decide. We can look at the best options for this. The discussion with the patient also need to factor in the doctor's views of the best course of action. Most patients would expect you to give your opinion, even if it's to make clear that the options have equal ratings. There can be consultations where the doctor feels there is an overwhelming appropriate course of action, and the minimum sharing you should be aiming for is to confirm the patient understands and is happy with the plan, and ask if they have any questions about it. At the other end of the spectrum are situations where any choice is okay, and there will be different choices depending on the patient's preference. the more patient-centered you have been with the data gathering, the easier this will be, as you will have a good idea of how the condition affects the patient and what preferences they had before the consultation. Remember, the patient always has the choice to do nothing. Towards the end of the data gathering, should be starting to formulate the management plan and ideally start to probe gaps in the data that enables the management plan to be better when you suggest it. So for an MSK pain, I might want to know whether they've ever tried NSAIDs in the past and how they got on. Does it affect their sleep? How you phrase the options will have an impact on the patient's decision. If you feel there are parts of the plan that should be accepted, then you make this clear and why. I would strongly advise X because. This is important because. I think we really should do this because. If you think more than one option is okay, then you can say this, but you must give the patient guidance to help with the choice. Does one have more evidence? Does one give more or a specific side effect? Is one awkward to take or carry out? Does one fit better with the effect on their life? I agree, this is gout again. It's good that you had some naproxen at home still, and that seems to have started working. There is another medication called colchicine that for most people improves symptoms faster than naproxen, although it often causes looser stools while you're taking it. Your last attack lasted for 2 weeks and you couldn't walk for those 2 weeks. It's been 3 days so far and you're clearly limping from the pain despite taking the naproxen. So your choice is to continue the same as last time with the naproxen, or you could try this other medication, colchicine, to see if that might work better. What do you think? Well, if you did get any loose stools or you felt it wasn't working, then we can go back to the naproxen again. Mild to moderate depression is a common example of where there are treatment options of equal value. A patient may choose to do all or none of them. For all the data gathering you might take during the consultation, ultimately there are choices of lifestyle, such as work, social life, exercise, counselling, type talking therapies, and medications. So for most of these consultations, you can start the management discussion by categorizing, giving the headlines of those options and ask the patient for their initial thoughts. For this kind of problem, we can break our options down into 3 groups that we can discuss. There are the lifestyle and things you can do yourself. So, for example, we can look at your work situation. You might want to think about exercise, social life things. There are the talking therapies like counselling and cognitive behavioural therapies. And there are the medications that might be helpful. What are your initial thoughts on those options? And this will usually allow the patient to direct where the main discussion goes next. If, for example, the patient says, oh, well, I definitely don't want to take medications, then it would have been a waste of time to go into a detailed explanation about them as the first thing you did. That doesn't mean that you can't later on ask why they were against the medications and see if you can give a brief explanation and open up that possibility that there is something they could consider in the future if needed. The handover here would be, great, so I will text you for the link for the counselling self-referral that you said you could do later today. You're aiming to go out walking for 10 minutes when you get back from work each day. You're going to speak to your wife about what we discussed today and to discuss whether medications might be something you would consider in the future. And I've booked a phone review for you in 2 weeks, but obviously you can contact me sooner if there are any problems. Is that all okay? A common situation that we see is an HbA1c that's going up. In most situations, there is the choice of lifestyle improvements and medications. So the medical factor here is how much has it gone up, i.e. how much damage is it doing at the moment, i.e. how quickly, how urgently do we need to get it down. With the medications, considerations include the usual for that medication, but also what does the patient think about taking more medications? Are they already on getting side effects from other medicines, and what's their overall polypharmacy burden? With the lifestyle option, do you know if that is feasible for the patient? How much difference are you guessing, are you thinking it's likely to make? So factoring those in, you can offer both options while advising your opinion. If the rise is mild, then you could suggest both but strongly push for the lifestyle improvements. If it's moderate, then you could advise both, but they could go for just the lifestyle if you think they could make a big improvement. And if the rise is higher, then you're strongly advising both. The blood sugars are up a bit, and the problem with this is over time it causes damage to blood vessels, eyes and kidneys. It's very important that we reduce that damage with better sugar control. We can look at lifestyle factors such as diet, exercise, weight loss efforts, and we can consider adding in a second diabetes medication. What are your initial thoughts on that? By asking for initial thoughts, we're not putting the patient in the awkward position of making them feel like they need to make an uninformed choice. The patient might give you some information about their lifestyle currently, their intentions, or their views on medications, and then you can use this to formulate the plan. The sugar increase is enough that we have to do something. I agree, it'd be great to avoid further medications if possible. I think to make enough difference with lifestyle measures alone, the change has to be fairly significant, more than just being a bit better with diet. I think it's going to need a proper plan for both diet and exercise. Is that something you think you could do? And then this brings us nicely onto lifestyle advice. There is little point in blindly suggesting random lifestyle advice to patients, as there is a low chance that person will be willing to make that change that you've guessed at. I think you should walk more. Can you try swimming? You'll be frustrated by the amount of why nots that you get back. You can think of this like a cone, like when we talked about the data gathering. You start with a wide open question and then you narrow it down to that point where you finalise a plan that you could hand over. You can suggest options, but try to give the patient a chance to suggest things themselves first and give the options as things to consider rather than an order. So there's good evidence that knee pain improves if the person has stronger leg muscles and less weight going through the knee. Is there any exercise you think you could do? Well, more walking would be good. How often do you think you could go out for a walk? Okay, and how long do you think you would walk for? Great. Is there any other exercise you think you could do? Great. Where would you go swimming? Okay, and how often do you think you would do that? So we have a plan then. So you're going to go for a walk for 30 minutes 3 times a week, and you're going to go swimming on Wednesday mornings. So that last line is the handover. This patient was ideal as they volunteered good suggestions. Probably more likely would be a more reluctant patient. So there's good evidence that knee pain improves if the patient has stronger leg muscles and less weight going through the knee. Is there any extra exercise you think you could do? Okay, well, the current best evidence suggests that even if initially you have pain when you're walking, that pain will reduce with time. In addition, there is good evidence that no painkillers make a difference long term. How would you feel about starting some home-based leg strengthening exercises that I could give you, and then build up to walking more? Good, okay. And is there anything else you think you could consider? Well, like a home exercise bike or swimming. Okay. Well, I'll print off a sheet with the home leg exercises. They take about 20 minutes if you were to do them all. How often do you think you could do that? Okay, great. Okay, and would you be able to put those dates on a calendar or somewhere else to remind you each week? Good, okay. Well, this is the handover. Here are the sheets. Try your best to do those exercises at least 3 times a week, and I would give it about 4 weeks, and then as well as the exercises, you can start walking a few times a week. Is that okay? A common situation is smoking advice. In most situations, rather than giving the order, you need to give up smoking, or I suggest you give up smoking, it fits smoother into the consultation if you ask, what are your current thoughts about giving up smoking? You can then follow up with more advice depending on the answer. If the condition was directly related to smoking, or stopping smoking would make a difference, then it's important to make that clear. I'm sure you're aware that giving up smoking would improve your breathing, probably more than the medications are. What are your current thoughts on that? Is there any way I could help you with that? So that's the end of the video. Aim to produce management plans that the patient wants, not what you want. Take into account the patient-centered information, ask the patient their opinion, and then when handing over, make your body language and tone of voice clear that this is the end stage. Okay, good luck.